Hello, Ekta ma'am.
Yeah. Yes,
All
yes,
set,
yes.
ma'am?
All set.
Okay, ma'am. Ma'am, we are live in next 30 seconds. I give you the number. Ma'am, we are live in 3, 2, 1. Please start, ma'am.
Good evening and namaskar, everyone. I would like to welcome you all on today's webinar, Dynamics of Radiation Prostate Cancer Refresher Snapshot. With immense pleasure, I would like to invite Dr. Kaustav, who is Director Radiation Oncology, Nanavati Max Super Specialty Hospital, Mumbai, for the further proceeding and for the welcome and introductory note. Over to you, sir.
I thank the organizers for the same. I also thank AstraZeneca and especially Mitali, who has worked very hard. I thank Horizon Conference for hosting this. So, there have been a lot of questions in prostate cancer radiation oncology. And on national forum, I see a lot of forums happening on uro-oncology, medical oncology, but radiation, there have been a lot of pertinent questions. That is, from standard fractionation, we shifted to moderate hypofractionation. And there is the concept of extreme hypofractionation. So where does the evidence come from? It's very important for us, the young radiation oncologists who have passed their degree maybe 2 years, 3 years back, and finally postgraduate students who are developing their concepts. So it's very important to know the evidence and know the journey from where it has started. Similarly, we are often confused about whether elective lymph nodal irradiation should be done. Is there a need? When should we do that? What is salvage radiotherapy? What is adjuvant radiotherapy? What is early salvage? Is early salvage a new concept? When do you combine androgen deprivation therapy with radiation therapy? So these are all and the trials, some the important trials like GETUP. So we thought these will be some important questions to answer in the format of a scientific program. And that is why we have all gathered here. And I just hope that at the end of this meeting, we will have some take-home messages and all these questions have been very thoughtfully put there. We have some answers to these questions. So without much ado and delay, may I invite Dr. S.K. Srivastav and Dr. Sonali Pingle. Mitali, you can introduce them and please invite them on the dais for the further proceedings, please.
Thank you so much, Kaustav sir, and good evening, one and all. So first of all, thank you so much everyone for being a part of it. I would like to invite Dr. S.K. Srivastava, Director of Radiation Oncology, SCGICS, Kubuchennai Cancer Center, Mumbai, and Dr. Sonali Pingle, Honorary Consultant Radiation Oncology, Dinanath Mangeshkar Hospital and Research Center, Pune, as the chairperson. And also I would like to invite Dr. Trinanjan Basu, Consultant Radiation Oncologist at HCG Radiation Center, Mumbai, who is going to talk and take us through the summary of evidence of moderate hypofractionation and SBRT. So over to you, Trinanjan sir.
Yeah, good evening. I will just share the screen. Yeah, the screen visible, I think.
Yes, sir. Your screen is visible, sir.
We can see.
So good evening, everyone. At the outset, thanks to Dr. Kaustav. This looks a very interesting topic and the whole program as well. So I have given the responsibility to speak on summary of evidence on moderate hyperfractionation and extreme hyperfractionation by SBRT in prostate cancer. Okay, so just to have a brief background about radiobiology, we'll not go into detail because these are often discussed in different meetings. So it's quite an old thing for about hypofractionation in prostate cancer. In the year 1999, the alpha by beta ratio for prostate, which was determined by these gentlemen, Brenner and Hall, and it was estimated around 1.5 gray. Over the years, in last 2.5 decades, there have been numerous radiobiological experimentation and alteration of radiation fractionations to determine this. And from this radiobiological experiment, only the clinical background has come about doing a change in the fractionation for delivering radiation while treating prostate cancer. So these are the main trials. The first 4 are a bit older ones, which used older radiation techniques, not many patients and mixed risk groups, mixed radiation techniques. And the later 4 are the often discussed prospective randomized trials, the 4 important ones, which kind of shaped and guided the moderate hypofractionation in prostate cancer. So between a conventional long course, about 7.5 to 8 weeks, to a moderate hypofractionated regimes, there's RTOG trial 0415, there's CHIP trial, there's HIPRO, and there's PROFIT. So if we just see the snapshot of them, they have tried to compare a standard radiation dose of about 74 gray and above in a 2 gray equivalent to an altered fraction, which is anything more than 2 but less than 5 gray. Mostly in this 4 trial, it was between 2 to 3.4 gray in different trials in a lesser number of fractions. So there came the concept of moderate hypofractionation. So what they wanted to see out of it, whether the biochemical control, the progression-free survival, and few have also commented on overall survival, though not very long-term data, are same, whether the toxicity remains same. So in a nutshell, they would like to see a non-inferiority design to the conventional long course fractionation and whether they can be then applied in clinical setting. So just to brief about these trials, the RTOG 0415 had more than 1,000 patients with a median age of 67 years. They have all, the trials included all low risk categories, and the randomization is between the long course radiation to about 28 fractions, so 2.5 gray per fraction regimes. They also have used a combination of radiation techniques. Fiducials were required for planning. If you look at the efficacy, the 5-year disease-free survival are similar between the two. So the hypofractionated regime turned out to be non-inferior to conventional with respect to 5 years of disease-free, 5 years of DFS. The overall survival also remained kind of similar. In the RTOG trials, the toxicity, the early up to the 90 days, there were no difference. And even the late, the grade 2 plus GI and GU also was not that great, what people were always skeptical about. Come to the next one, the often used, the CHIP protocol, which had about more than 3,000 men with across 71 centers of UK, Ireland, Switzerland, and also in New Zealand. With a median age nearing 70 years, they had intermediate risk category also, low and intermediate. Also, there were use of ADT, randomization between 3 radiation schedules, 74 grade 37 fraction, which is the long course standard one, to 60 in 20 with 3 gray per fraction, and another arm of 57 in 19. So 1 fraction less. They were all IMRTs and 30% also had image guidance. So what they have found, the 5 years biochemical recurrence-free survival also are more or less similar in the either arms, but the 60 gray is non-inferior to 74 gray, but 57 gray is not non-inferior to 74 gray. So the last fraction of radiation also counted. This trial was, although not designed to compare between 60 and 57, the overall survival had no differences. If we see the toxicities, the grade 2 plus of GI and GU were more or less equivalent between the standard to the altered fractionation arm. And the peak early, but the later on there are no differences. And even the late toxicity at 5 years in CHIP, the grade 2 plus GI and GU are between 10 to 12%. Remember, they're all IMRT treated although, but all of them didn't have IGRT. The cumulative more than grade 3 toxicity was less than 4%. Now coming to the PROFIT one, which was in Canada, Australia, and France, more than 1,000 patients. They had intermediate risk category and randomization between a 78 gray to 60 gray 20 fraction. So this is most of the 2 commonest regimes we all are knowing. They were IGRT. The 5-year biochemical recurrence-free survivals are more or less similar, same as the overall survival, and also the toxicity. So the late toxicity actually has favored the hypofractionated regimens in this. So it was again concluded to be non-inferior. And the last one, in the HYPRO, there's nearing less than 1,000 men with median age of 70 years across 7 centers in Netherlands, with they have 74% of the patients as high risk. So among these 4 important, this is the only trial which included high risk. 66% received ADT and randomizations between a 78 gray radiation in 2 gray equivalent to a 19 fractions regimen of 3.4 gray equivalent. So again, more or less similar outcomes. So the interpretation in this that hypofractionated is not superior, that's how it was designed. And it was consistent with also in the higher risk category. And there were no difference in overall survival as expected. So the HYPRO trial has went on, and actually they have compared the ultra hypofractionated arm also with the conventional fractionation. In their ultra hypofractionation, it was a 7 fraction regimen, and it was published in 2019. And this is one of the key support of the SBRT cohort also, which we'll come to later. So if we do a SWOT analysis of these published moderate hypofractionated data, so the strength where they're all phase 3 randomized control data with a decent follow more than 5 years. Cumulatively, more than 5,000 patients across these 4 main trials were treated. They all have reported biochemical control-free survival, progression overall, as well as the toxicity data. But the weaknesses would be there were non-uniform radiation techniques between combination of 3D and IM, non-standard as of standing today at 2022, many people were treated with 3D CRT, and that's maybe a reason of showing the higher toxicities. And the risk category representation was non-uniform, especially in our scenario. Only HYPRO trial had high risk cohort. But this led to window of opportunity of doing more prospective evaluation with other protocols, randomization between moderate and extreme by doing SBRT. Importance, it also reiterates the importance of hormone therapy, and also opportunities to see high-risk specific data in different single institution as well as randomized cohort. The threats would be, as always highlighted by even many radiation oncologists, not only our other Euro colleagues, that the long-term data are not available except for the HYPRO trial. The uniform and as of today standing and modern IM-IGRT cohort was not there in these 4 trials. The dose standardized was also not clear. Different institute use different doses in moderate, and they require training and expertise by switching for long learned techniques of conventional to a bit moderate to extreme hypofractionation. But people have realized that this is giving benefit by reducing a 4 weeks of treatment time for someone. This adds definite benefit, and that's why in 2018, the ASCO special issue has an ASCO and EU with consensus guideline for the use of hypofractionated radiation. It's a long article. I would encourage the students to read. They try to address these 8 important questions of what and where the moderate hypofractionation to be applied, what the technique would be in that, what is the requirement of image guidance, what to choose between conventional, moderate, and ultra hypo, and in regard to the outcomes of prostate cancer specific survival, toxicity, and quality of life. So the key points which came out of them are moderate hypofractionation is applied across all risk groups. It is not affected by age, comorbs, or baseline IPS scoring or anatomy, which has a strong agreement out of these consensus statements. In this consensus statement, it was a conditional statement for SBRT for low risk organ confined disease. For the high risk, it should be under a clinical trial. Dose beyond 40 gray for SBRT also should only be evaluated under a clinical trial. But this also led to a window of opportunity between a randomized control trial evidence and a real world evidence. So which we'll see in subsequent slides, how the real world evidence matters more. And from this consensus statement, there's a strong recommendation for using intensity modulated image guided treatment for doing these altered fractions regime for prostate cancer. Similarly, across Atlantic, also European consortium have realized the importance. So they have also published their guideline for the high risk and the intermediate risk, what sort of radiation fractionations can be applied. And more or less their guidelines have strong agreement. Now, if we see by that time, because none of these trials has representation from Asia Pacific regions, but in India, there were multiple single institution protocols between mid 2000, around 2015 onwards to till now. So Dr. Indranil has published from TMC Calcutta phase 1, phase 2 study of SBRT for once weekly treatment. And important to note that there are about 67% of the patients were high or very high risk in these data. Similarly, it was also published for the node-positive patients to apply moderate hypofractionations as the CHIP protocol, with adding also the pelvic nodal segment. It also had a uniform representation across the risk groups. Dr. Vedang sir has published numerous articles in different risk cohorts in going ahead with extreme hypofractionation for even high, very high, and node-positive prostate cancer. If you see the risk grouping in this, there are many patients who are node-positive in his data. And also, similarly, in the from American data, there's one publication of the SBRT with also covering pelvic nodal irradiation, as Dr. Vedang has also published. Sir has also published among the after the post-start, which is very common in our scenario, whether it is safe to do it, and we can pretty well see these articles later in detail that there were no exaggerated side effects as always highlighted by these. But where is the roadblock? So this article which got published about the prostate radiotherapy in India and what were the challenges in that. So I was also one of the participants in this questionnaire. So what came out of this publication is that many a times these patients were seen by community urologists to begin with, and there most of the treatment are either orchidectomy or sort of a TURP, and they're putting on some hormone tablets. So by the time they're coming to a multidisciplinary onco setup for uro, there most of the treatment are done maybe wrong and maybe not adequate. There are no most of them are non-MDT, a multidisciplinary tumor board, non-availability based approach. There are concerns about training and IGRT availability and application. And always there is skepticism about long-term data, which we keep on talking in many articles. And in India, we mostly see high-risk or high-risk node-positive disease, which unfortunately these randomized trials have not addressed till then. Now, parallelly, as we are talking about real-world evidences, the real-world evidence have published. There is systematic review and meta-analysis over 6,000 patients for SBRT. There are long-term results published across different single center or a single country, different centers on moderate hypofractionation. And also the Australian, New Zealand people have published their patient-reported outcome, and which all have quoted it to be safe and more or less similar to the long course. So why to trouble someone for a long course radiation? Now, recently, the German consortium has also published their SBRT working statements, and these are the points to look for. In a summary, there should be a proper IGIMRT trained and expertise setup. The ADT administration remains similar as we used to do as per risk category. It will not change except maybe for the favorable intermediate risk, where SBRT alone can be applied, and so on and so forth on EQD2 and other features. So this is a very recent review in Nature's Review Urology on the practical considerations of applying the prostate hypofractionation in a developing world. So if you see these papers, they have given comments on prostate size, IPSS, risk stratification, where to apply, the dose per fraction, what we will rename them, the strong recommendation of image guidance and intensity modulated radiation, and also PTB expansion. So I don't agree much to the point of prostate size less than 100 cc. The other points are more or less we are already following. They have also done a cost-effective analysis in this review, and most of the time it is found SBRT to be cost-effective than long course treatments. So now what to choose between whether to choose a moderate hypofractionation or an extreme hypofractionation by SBRT. So like we talk about the randomized data, so we are fortunate there's an Indian trial by Dr. Vedang and Dr. Indranil going on, the PRIME trial between a moderate hypofractionation regime to an extreme hypofractionation by SBRT. And also the good part, it has included high risk and node positive disease as well, because the other ones, the hypo-RTPC, which already have published the 5 years data, and the NRG trial and the PACE trial, they are mostly limited to low and intermediate risk. So which might not answer the questions we always look for in an Indian setting. So what is the future in this hypofractionation, whether to choose moderate or extreme? This very recent editorial I have tried to address this. This is to be read in detail in spare time, whether why the brachytherapy is important or it is reducing, why it is in use, whether SBRT will slowly replace it, whether proton will come into role, whether this extreme hypofraction can further be extreme to single or two fractions regimen. So these ProScient and one-shot trial might answer that, and the proton-related trials which are undergoing. So we'll have to wait before commenting on this. So the statement, I know Dr. Rohit would sum up in the end between moderate and extreme hypofractionation, what is to be chosen. The important is to choose the right cohort, to have the right technology and right expertise. And I would also like to emphasize that the real world evidence also matters, because there are many, we as radiation oncologists treat many cancers. If we have to wait for real randomized data, then we might not be able to apply anything. So if you have a technology and training, it is also important to see real world evidence to apply them. Thank you.
Mithali?
Hello. Thank you so much, Dr. Trinanjan, for taking us through your presentation. I would like to invite Dr. Vedang Murthy, Professor and Department of Head of Radiation Oncology, Attract and Tata Memorial Hospital, Mumbai. And sir is going to take us through the elective lymph node irradiation. Is there a need? Sir, over to you, sir.
I am having trouble with sharing. Mithali, can I?
Yes, sir.
Can you just go to the next presentation? I'll present after this, if that's okay.
Surely, sir, not a problem. So I'll take the next. Just a moment. So moving forward, I would like to invite Dr. Kinjal Jani, Director and Head of the Department of Radiation Oncology at HCG Cancer Center, Ahmedabad. And sir is going to take us through the summary of evidence of early salvage therapy. Is this the way forward? Kinjal, sir, over to you, sir.
Kinjal is there? Kinjal, are you there? I can't see Kinjal's name.
I think meanwhile the Vedang can try. If you can share the screen.
I'll just give a call to Kinjal, sir, till that time.
Vedang, why don't you...
Anyway, to keep the discussion alive, Trinanjan there?
Yeah, yes.
So till they sort this out, what is your take? When will you take the patient for SBRT? I know Rohit is going to sum them up. Rohit is also there. When will you take the patient for SBRT?
So two-liner, for moderate hypofractionation, I think all risk categories can be doing moderate hypofractionation. For SBRT, even to be honest, I am quite comfortable doing prostate with pelvic nodal as well. But as a teaching statement, maybe up to all intermediate risk, the point is where you might not have to treat the pelvic node.
So Trinanjan, when we say, for clarification to students, when we say pelvic nodal, do you consider the criteria of number of node, volume of node, location of node?
No, I mean elective pelvic nodal here, like we do for high risk. So whether you follow Roche formula or the MSKCC.
No, that's what. So volume. Do you consider volume if you are doing elective?
No. Actually, you mean volume of prostate? That way you're saying?
No, the total irradiated volume.
No, I don't think. No. I think
Rohit, you are there.
Yeah. So I think, Kaustav, what you are talking about is, patients with regional node positive prostate cancer. I would personally not be using SBRT in that category of patients. I would restrict myself to, conditional for low, intermediate risk, categories. It's very, very safe. We've got adequate data. There's a lot of confidence, for prostate only radiotherapy. What Triranjan is trying to say is elective, where there is,
of course, yeah.
So in this select group of patients where you've got high risk category prostate cancer, where there is no extension posteriorly, and if it is a T3A or a T3B involving the extra prostatic capsule or going anteriorly and not posteriorly, then in these scenarios it is very reasonable to go with SBRT and try and address the elective nodal radiation. So
right.
yes.
So yes, no. So we understood that. I think he was talking about elective nodal. I was talking about the volume of the total volume irradiated in an SBRT setting. Are you comfortable giving such high doses?
No, I'm not. So I would restrict myself to only those where I do not have to treat the pelvis, where I have to treat only the prostate. So prostate only, it is really, really good.
So now I'll just interfere here. If Dr. Vivek Venkatraman is ready, Vivek is ready, then he can start with his talk and Vedant can join in later. Is that okay?
Sir, thank you.
Yeah.
Yes, sir.
So Mithali, can we have Dr. Vivek talking now?
Yeah, absolutely, sir. We can definitely take it forward.
Okay, can you see it?
Yes, sir. So I would like to invite Dr. Vivek Venkat, sir, Senior Consultant Urology and Robotic Urology at Nanavati Max Super Speciality Hospital. And sir is going to take us through the patient journey and the GETUC AFUG trial, sir. So over to you, sir.
Thank you. Thanks to the organizers and my thanks to Dr. Talpatra, sir, for this opportunity. My only disclosure is that I'm not a radiation oncologist. So if you have any questions, I think they're the ones who should be answering them. So let's just go through. They wanted me to talk a bit about the patient journey and the statistics for prostate cancer first as the introduction. So it is one of the most common cancers worldwide with almost 1.3 million new cases per year. In the West, it is actually the #1 cancer. In India, it is somewhat lower down on the list. And it is, despite being so common, it's only the 5th leading cancer cause of death in men, because there are much more lethal cancers as compared to prostate cancer. And of course, we know that there is a great geographic variation. Prostate cancer probably in terms because of screening practices also, it contributes to a large incidence in Western countries, while the mortality is maximum in the sub-Saharan African regions and the Caribbean, where access to healthcare may be more of an issue rather than, and also the biology of disease in those of an African race is definitely worse. So just to give an example of how common it is, just a few really famous people who have been diagnosed with prostate cancer. We have Colin Powell, Rudy Giuliani, Robert De Niro, and even James Bond, Sir Roger Moore, one of the longest playing James Bonds, he couldn't outrun his prostate. So it's such a common problem there, and it's a real public health menace in that part of the world. So in India, it's about the 16th most common cancer with an incidence of about 25,000 odd cases a year, but definitely underreported. And ultimately, those with metastatic disease will go on to CRPC and may even die from the disease. We still see the majority of patients still presenting to us often in locally advanced and metastatic stages, as opposed to what we see in the Western part of the world. And of course, we know that this has a major impact on the survival, because the prognosis is determined by the stage of the disease. So in stage 1 and 2, we have almost 100-year, 5-year survival, and it drops drastically once you reach a metastatic setting. And the grade of the disease too plays an important role in terms of prognosis of the disease. So when we are talking about classification of the prostate cancer, we use the terms localized disease, regional, and metastatic. So of course, it's very clear what regional and metastatic are. When we come to localized disease, we can classify them as low, intermediate, and high risk prostate cancer. And there are a number of classifications, but what we really need to know is low risk is those who are Gleason 6 with fewer than 3 or maximum 4 cores, or means ISUB grade 1, and with a PSA generally less than 10. However, in India, we do see patients having a much higher PSA, even when having a relatively low volume of disease. So we may need to tailor that for our setting in a way. And the importance of low risk disease is because active surveillance should play actually a very important role in this setting. Then high risk disease is that which is locally advanced in the sense of T3 and T4 disease, very aggressive cancers, ISUB grade 4 and 5, and also those with a very, very high PSA, generally recommended as more than 20 in most definitions. So whatever is not low or high falls into intermediate. And the importance is high risk, again, often requires a multimodal approach to treatment, and telling that to the patient upfront, really streamlines the process downstream. So this was a Nobel Prize winning discovery. As everyone is aware, prostate cancer is hormone dependent, and we have a number of indications where we do use androgen deprivation therapy like Zoladex throughout the different stages and different course of the disease. So generally, like we saw, it may be you start off with a primary treatment. So this is the patient's journey. Hopefully your primary treatment is absolutely successful and they don't relapse. But if there is a relapse, you would have an adjuvant or an early salvage treatment in cases of biochemical recurrence. And if they fail beyond that, they may progress to metastatic hormone sensitive disease and then castration resistance. And of course, we find a lot of men who do present to us directly in the metastatic setting. So in the localized setting, just a couple of examples of celebrities. Warren Buffett, I know a lot of oncologists in general are very much into the stock market. So he's one who actually probably understands risk better than anyone else in the world. And he chose to have radiation for his localized prostate cancer. Stephen Fry, famous British comedian, had surgery for Gleason 9 disease about 2 years ago. And then just a couple of sadder stories. Young men who presented with metastatic prostate cancer, Bob Willis, who passed away from metastatic prostate cancer, and of course, Gunther from Friends, very young at the time of death of just 56 or 57 years. So just to show how common prostate cancer is, what can be the various spectrum of the disease, and the importance of androgen deprivation throughout various different stages of the disease. So let's just move on to the case and the real meat of the presentation in terms of the GETUC trial. So just a 64-year-old man who was actually diagnosed during just as COVID was starting in June 2020 with a PSA of 43 and an ISUB grade 2 on the biopsy. The PET scan at PSMA at that time showed localized disease. And because of COVID, he was given ADT. And then he finally came to me in December. At that time, the PSA was, I think, 1 or 2. And he then said, now let's do the surgery. So he underwent a radical prostatectomy. The PSA was undetectable for 9 months. And in September, we had a first PSA reading of 0.14, November 0.3, and the PSMA PET scan showed no obvious disease. And actually in December also, it was 0.34. So this takes us to our topic for today, which is the GETUC AFU16 trial. And so this was published in 2 separate publications in the Lancet Oncology. First one in 2016, which reported on the primary endpoint, which was the biochemical, means progression-free survival. And the second one, which reported on the metastasis-free survival. So this is basically a trial in which short-term hormone treatment, which was Zoladex, was given for 6 months as part of the salvage protocol. So what was the study hypothesis? About 1/3 of patients relapse after radical prostatectomy. and salvage treatment is generally pretty effective and safe in this situation in terms of salvage radiation. And so they wanted to study whether the addition of short-term ADT improved progression-free survival and metastasis-free survival in this population. So this was a phase 3 multi-center randomized trial across 43 centers in France. It was a fair amount of time ago, begun in 2006 and completed accrual in 2010. The primary endpoint was PFS, which includes biochemical or clinical progression or death. And the PSA rise taken for biochemical free survival was a PSA rise of more than 0.5 above the nadir. And secondary endpoint was actually the main endpoint was overall survival because the events were so low, they actually looked at metastasis-free survival as a surrogate for overall survival. And this was defined as any clinically documented metastasis or death of the patient. And they did do a subgroup analysis classifying patients as low risk and high risk. Low risk were those who were Gleason 8, below Gleason 8, those with positive surgical margins, a PSA doubling time of more than 6 months, and no seminal vesicle invasion, while high risk were the opposite. So this included patients who underwent radical prostatectomy, T2 to T4A. 4A included only bladder neck invasion. Lymph nodes were N0 or NX, means no lymph node dissection may have been done at the time of the prostatectomy. Post-op PSA should have been undetectable for at least 6 months after the surgery. So this is kind of our case, kind of classically fits into their definition. And biochemical relapse was confirmed by 2 tests, and the PSA level remained between 0.2 to 2 nanogram per ml, a pretty restrictive range at the time of initiating the salvage radiation. So any patient who had prior ADT, prior pelvic RT, N1 disease, non-adenocarcinoma, or any other simultaneous cancer was excluded from the study. So this is how they were randomized, 1:1. One group, the study group, received 6 months of goserelin with radiotherapy, and while the control group received radiotherapy alone, 66 gray in 33 fractions, 5 days a week for 7 weeks. Seminal vesicles, if there was T3B disease, was treated with a separate 50 gray dose, and the pelvic nodes, if the Partin tables showed a risk of more than 15% and no lymph node dissection had been done at the time of surgery, then that was also treated with another 46 gray. So the initial report of progression-free survival was in the Lancet in Oncology in 2016 at 63 months. And then they reported the longer term of almost 10-year follow-up data. So these are the baseline characteristics for both the groups. They were pretty similar, and the PSA at randomization is about 0.3 in both groups. So it's a pretty low PSA at which salvage treatment was started, which is ideal. So this was the first paper, 2016, which showed a significant benefit for those who received goserelin in addition to radiation in terms of their progression-free survival. So wins a hazard ratio of 0.5. So that's really strong, and p-value of less than 0.0001. So significant benefit in both progression-free survival at 5 years. And as expected, addition of ADT was pretty safe. Hot flashes and sweating were the most common side effects, and it really did not add much to morbidity in this particular group of patients. And if you looked at the various high risk and low risk characteristics, it was maintained. The benefit of goserelin was maintained across the board in this study. So overall, it showed almost a 46. And then in 2019, they reported the 10-year follow-up, which showed again similarly almost a 46% reduction in the risk of progression over 10 years with goserelin plus RT versus RT alone. This is the metastasis-free survival graph for all the patients at 10 years. So the overall survival was pretty similar in both the groups, 86 versus 85%. The patients did really well overall, so they really could not find any overall survival difference. So that's why they report on the metastasis-free survival. Even though the curves look pretty close together, there is actually a significant benefit for those who received ADT in addition to radiation treatment as well. So the p-value being 0.033. But if you look at the low risk and the high risk subgroups, the PFS was definitely better, but the metastasis-free survivals were not significantly different among both the groups. But when you combine these two groups, it does show a benefit. So a bit of statistical anomaly here probably, but it just shows that they were probably not adequately powered for getting differences between the high risk and the low risk subgroup. Similarly, when you look across multiple different factors in a subgroup analysis, again, the high risk and the low risk factors, there was no significant difference for the 10-year metastasis-free survival. So even though this showed a definite benefit in progression-free survival and a soft or a modest benefit in metastasis-free survival, there are some limitations to this study. Biochemical relapse in prostate cancer can be considered, a really soft endpoint. Because it cannot always correlate with mortality. The patient survival was so good in this particular cohort that a longer follow-up is needed to show any overall survival and even any subgroup benefit. And they used a very narrow range. And so they started treatment so early that the probability of showing a response may have been reduced because the patients they were selecting were generally good risk, as opposed to the other RTOG trial, which also included patients who had biochemical persistence of PSA post radical prostatectomy. So that is kind of a difference, maybe why they weren't able to, show the proper difference in overall survival. And of course, this study is almost initiated almost 15, 16 years ago. And I think I don't need to tell any of you that there has been a significant improvement in the technology and the way radiation has been given over each passing year. And also in terms of the imaging, there was no central review of imaging. CT and bone scan, as is still in a lot of places, the standard of care was used, and not any of the newer imaging treatments, which have, kind of changed a lot of staging in terms of prostate cancer today. So in conclusion, the addition of 6 months of goserelin to salvage radiation does significantly improve the 10-year progression-free survival with a modest benefit on metastasis-free survival. Longer follow-up is probably needed to demonstrate OS and disease-specific survival benefit. High-risk groups are more likely probably to benefit, but they may need also a longer duration of ADT. So as per the EAU guidelines, it can be offered to men as part of the salvage radiation protocol, but the level of evidence, they say, the level of the recommendation is weak. So I guess this man, he went for salvage radiation. I think Dr. Talpatra just finished giving him his salvage treatment about 2 or 3 weeks ago. So it was a pretty good case, probably not fitting exactly into this because he had already received ADT, but in terms of the other criteria, he did fit very well. So thank you very much. And thanks to the organizers once again for this opportunity.
Thank you so much, Vivek sir. And I would like to invite Dr. Vedang Murthy sir, Professor and Department of Head of Radiation Oncology at RACT, Tata Memorial Center, Mumbai. And sir is going to take us through the elective lymph node irradiation. Is there a need? So over to you, sir.
Right. Thank you. Thank you, Mithali. Thank you, Kaustav. Whether there's a need for a whole pelvic radiotherapy or not, I'm not sure. well, we'll see, but I certainly need more training in Zoom even after 2 years of doing this. There were some technical issues, so sorry about that. And my regards to Dr. Srivastav, I think he's still here. With that, I'll just start. So whole pelvic radiotherapy, is there a need? And I will cover, give me a second. Okay, I'll cover in node negative disease and node positive disease. I'll also talk with different fractionations in particularly node negative, and I'll touch upon how we can use PSMA to optimize node positive whole pelvic radiotherapy. So this is not a new problem. This has been going on for the last 40 years. Why would we want to treat whole pelvic radiotherapy in patients who don't have nodes? We do it for many cancers. Unfortunately, in prostate cancer, this question has bugged us for the last 3 or 4 decades. We want to sterilize occult metastasis in patients who are at a high risk of lymph nodal metastasis. And with this, we want to improve our hope that we improve outcomes while minimizing toxicity. There are 3 trials that I'll talk about. The first one is a French trial called GMT202201. This was published in 2007, way back. I had just joined as a faculty at that time at Tata Hospital. 400 odd patients randomized to receive 66 to 70 gray to the prostate, and one of the arms got 46. One of the arms got pelvic radiotherapy as well, and that was 46 gray. All the patients received some 6 months of ADT, and there was no difference that was found in the outcomes. Now, the same group, they published much more recently in 2016, when I had already become a professor. So that's 10 years later. Median follow-up of 11 years. There was essentially no difference that was found, but they also found a very odd finding that they couldn't explain. And this was that low-risk patients who had a lymph nodal risk of less than 15% somehow seemed to benefit. And they actually wrote in the discussion that basically this should be taken with a pinch of salt. So that's what we're going to do that. And this trial has essentially not answered the question. Okay. Now we move on. There were issues with this trial. A large majority had less than 15% lymph node risk. So they were actually not high-risk patients. Smaller fields were used that I'll show you just in a little while. Standard radiotherapy, I don't think any of the dose or technique can be considered as standard as of today. So we leave that trial aside. More practice-defining trial was called RTOG-9413. This was done by Professor Mac Roche. All the patients had a lymph node risk of more than 15%. 4 arms. They were trying to answer 2 questions, and that I think became a problem and their own, I would say, fall of the trial, because it became so complicated. They wanted to study about port only or prostate only RT versus whole pelvic RT, and neoadjuvant versus adjuvant. Remember, all the hormone therapy in this trial was given only for 4 months. Right. The first results were published in 2003. I was just a senior registrar at that time, and this kind of defined practice. What they said, 1,300 patients, 5 years, whole pelvic seems to be better than prostate only RT. In 2007, along with the JETEC, this update came, and you could see the 5-year, the difference. When they published at 7 years, it basically went away. So there was no difference. They said, no, it doesn't help. Now, and nobody knew what to do about it. This was 2007. They published about 3 years back in the same group, Dr. Roche, and they published a paper that had 4 lines like this. And I'm not even sure the authors knew what to make of it, although they wrote some things. I don't think anybody has figured out this whole issue about whether it's what is the benefit. And a very interesting editorial from Pascal Pommier, he's the PI of the French trial, said that this is probably the key study, but one of the also the most confusing in prostate cancer radiotherapy. Essentially, you can't make out what is happening. And the major reason was interaction with the ADT. 70 gray was used, conventional RT, and 4 months of ADT. They also looked at the volume of pelvis that should be used. So they had patients who had prostate only. They had patients who had what is called as mini pelvis that was at L5S1. And they also had some patients who had higher pelvis depending on the center. And it did seem at that time that the pelvic volume where you took your upper border seemed to be making a difference. But this was just a paper in 2007 and nothing more was done about it. So what is the answer to the question, does pelvic radiotherapy benefit a patient with high-risk prostate cancer who has been staged with modern imaging, treated with image-guided or intensity-modulated radiotherapy to a dose that we would consider a standard equivalent to about 74 to 78 gray, and an appropriate duration of hormone therapy? We couldn't have said this for sure till recently. And many of you have seen this recent publication. For those who have not, this was published about 6 months back in the JCO. This is a trial called POP-RT, prostate only or pelvic radiotherapy in high risk and very high risk prostate cancer. This was done at Tata Memorial Hospital. Just to get on the same page, high risk and very high risk defined as we have given here. The idea was to see if whole pelvic RT benefits. The trial was started in 2011 and completed accrual in 2018, and we published last year. All patients had a lymph node risk of more than 20%. These were various inclusion criteria. Everything led to a lymph node risk of 20%. A large majority of patients had PSMA PET-CT at baseline for staging. They were randomized based on these stratification factors to standard of care, which was considered as prostate only or whole pelvic RT, and all patients received at least 24 months of ADT. The primary endpoint was biochemical failure-free survival. It is not a very strong endpoint, but that was done more out of practical reasons, because if we had made metastasis or overall survival, the trial would never have taken off. All patients got image-guided daily moderately fractionated RT. Trinanjan made a very nice presentation about the fact that moderate fractionation should be the standard of care. We were fortunate enough, or probably brave enough, to have jumped onto the moderate hypofractionation bandwagon very early and made it the hospital standard in 2010-11 itself. 68 gray in 25 fractions is a very high dose, as I'll show you in the next table. The pelvic RT patients received 50 in 25. So it was 25 fractions was made to make it very practical. And we made sure, because at the time of designing the trial, the discussion was going on, where should the upper border be? And because we knew we were fortunate enough to be able to treat all these patients with IGRT and IMRT, we again probably were brave and went ahead with treating, making sure to go high enough to include the common iliac. Probably all these decisions paid off. As you can see, the primary endpoint, after a median follow-up of 68 months, we have a large difference in the biochemical failure-free survival benefiting the whole pelvis RT, a large difference in disease-free survival, but no difference in overall survival as of the time of analysis. you may not know this, but in 2010-11, DMFS was not a big deal. It was not considered a surrogate for anything. It was not a thing. So we had not written this in the protocol. But over time, DMFS became a very strong surrogate for overall survival. So this was a post hoc analysis. I don't think that really matters because what we found was that if the DMFS was also significantly improved with whole pelvic RT. And this is a very, very strong endpoint, which may just lead to an overall survival difference over the next 3 or 4 years. You can see the hazard ratio is 0.35 for distant metastasis-free survival. So this is probably the strongest outcome point from this trial. You see, if you looked at the patterns of failure, most of our patients, almost all our patients had a PET CT at biochemical failure. And you can see here of the 29 failures in the port arm, there were 15 who had some component of regional pelvic nodes, whereas of the 7 failures in the whole pelvic, only 1 had a. So it appears that the 50 gray seems to be enough to sterilize the micrometastatic disease in the pelvis. And when we didn't use pelvic RT, there were so many failures in the pelvis. We looked at different subgroups, prognostic subgroups. There was nothing that stood out. All the prognostic subgroups seem to be benefiting with pelvic RT. There was a surprising finding that younger patients seem to be benefiting more than older patients. This is just, there is no explanation for this that we have. It is probably just a matter of chance or maybe just a hypothesis generating point. This is probably the most important slide, why we got what we got as compared to what the Americans or the French did. We chose the lymph node risk better probably. A lot of the patients, more than 50% of the patients had the high lymph node risk. Median pelvic nodal risk was 38%. Half of the patients had Gleason 8 to 10. You can see here in the American trial, 72%, but that includes 7. So don't go by that. We don't know how many were 8 to 10, but in the French, there were hardly any. We had PET scans. We were again fortunate. This made I think it made a difference. We are not sure about that. This probably made a difference. L4, L5, we included the common iliacs because we were using IMRT, unlike the other trials. A high dose, in high-risk cancer, a high dose is required. We gave a BED of 130 gray with this kind of fractionation schedule as compared to these kind of doses. So we had much fewer local recurrences, and hopefully that led to the improved outcomes. Technique, I have already told you. And ADT also, we gave a long, at least 2 years. So all these things probably came together to give us the results. So is pelvic RT for all high-risk cancer patients? This is a huge debate going on, and I would really want you to go through this excellent review article by a whole lot of French, European experts who wrote about our trial in the Lancet Oncology very recently. And they said that the trial established that whole pelvis should be done for more than 35% lymph node risk. So we wrote a rebuttal to that look, the trial did not say that the benefit is for more than 35% lymph nodal risk, but it is for all patients. So we actually did this is not published. We have looked at all our failures and what their lymph node risk is. There is no particular, particular cutoff after which the risk of failure increases. All patients above 20% should be offered pelvic radiotherapy, according to the trial at least. This also very nicely highlighted how this trial was different in terms of coverage of lymph nodes. You can see this is a beautiful diagram saying that we went up till the common iliac in green, common iliac bifurcation. There are some recent updated NRG guidelines that you may want to look at for contouring the nodes. It has made changes in how nodes should be contoured, brought in vascular anatomy, they brought in modern imaging, they brought in some constraints, and we were just fortunate enough that we had incorporated all these things in the trial already about 10 years back. So that is very gratifying. Okay, it comes at a cost. The whole pelvic RT comes at a cost. Does it increase toxicity? Does it worsen QOL? And really, does it matter? So the final analysis showed that there was a surprising finding. This was not surprising because we had already published this, as I'll show you. About 20% of patients in the whole pelvic arm get grade 2 or higher GU toxicity. Urinary, remember this is urinary toxicity, as compared to about 7 to 8% who get in prostate only, grade 2 or higher. There was no difference in the GI toxicity grade 2 or higher. We got only about 6 to 8% of GI toxicity. Intuitively, you would think if you're treating the pelvis, the GI toxicity will increase, but that did not happen because of IMRT. We had published this study about 2-3 years ago in, well, it was just 2020. So we looked at the toxicity outcomes, and the same thing was published, that urinary toxicity and a whole pelvis increase urinary toxicity. And the reason we suspect is that the medium dose ranges, V40, V30 is higher with pelvic RT. As expected, you treating the pelvic side walls, the bladder does get irradiated. This has not been found in other trials, but we are re-looking at the data as well. But I'm pretty convinced the urinary toxicity with pelvic RT is high. There was no difference in the quality of lives. With that, I'll move on briefly to SBRT. Is whole pelvic RT needed when you are treating with SBRT? We have finished moderate hypofractionation. Well, biology doesn't change by technique, so it will be needed. Very nicely shown in these 2 candidate trials, both treated with SBRT, different trials. One treated the nodes, one did not treat the nodes. And when you did not treat the nodes, there were higher failures. This is not randomized, but just proof of concept that even with SBRT, you will need to treat the pelvis. The benefit is just too large to not treat the pelvis. The whole pelvic story for SBRT began with a lot of stuttering and shocking outcomes from a trial called FASTER. They had 25% grade 3 toxicity. And that's a lot. And the trial had to be terminated. But it was not because of pelvic RT. They, as I'll show you, further trials have looked at whether pelvic RT is okay with SBRT, and it is fine. There is no problem. We have also published our data. There is no increased grade 3 toxicity. It is okay to treat with pelvic RT. It is safe. And as I was telling you, the original FASTER, which gave shocking results, was because of poor dose constraints that were given for the primary and not because of the pelvic treatment. So important to remember. So node positive is a problem that we all see. I don't have to tell you. In the survey that Trinanjan very nicely showed, one of the things was we use a lot of PET. And because we use a lot of PET, we find node positive disease. This is a classic example. You can see the prostate. You can see a node here, a couple of nodes, bilateral nodes, baseline. When we scan them at about 4 to 6 months with another PET, we often see, and we have published this, is the prostatic uptake remains, whereas the nodal uptake very often goes away. I would say 70-80% of the times, and you may also have seen the nodal uptake reduces, or in 30-40% times, it completely goes away. So using this approach, can we use the PSMA? That's our strength. Can we use it to treat, optimize the treatment for node positive better? So what we did, this work was done by my Dr. Tejashri. She was my research fellow. We published this about a year back. 60 patients, all were node positive, all had PSMA PET. They were all started on ADT. They received it for an average of 6 months. A PSMA PET was repeated, and they were all treated with SBRT. So very standardized cohort. We looked at the second PSMA PET and treated the radiotherapy according to that, whether to give a boost or not to give a boost. All of them got pelvic RT, but only if a residual node was there on the second PET, we gave a boost. And obviously the prostate was treated. So not a very long follow-up, but excellent outcomes you can see here, and not very high toxicity. So node positive prostate cancer treated with SBRT, the toxicity rates are still quite low if done properly. We found some interesting hypothesis generating data. Surgical castration seemed better. Small number of patients, but maybe longer ADT seems better. And those who got a boost using PET seemed better. And we are doing some more work on this, and hopefully this will lead to some PET-based radiotherapy publications soon. This is the trial that Triranjan also showed, a trial that is ongoing, and I must thank, among other people, I think Dr. Adulkar is here. She wrote the first draft of this protocol, and in fact, even the final one, and got it approved. So thank you, Deepanjali. This is ongoing trial, 464 patients. Node positive, basically high risk, very high risk, and node positive cancers, the typical patient that you see, Gleason 8, T3B, etc., PSA 40, randomized to the standard arm, which will now be moderate hypofractionation after POP-RT, along with pelvis, or SBRT along with pelvis. So we are at around 260 now. Dr. Indranil is part of it. And hopefully very soon we will have Dr. Srinivas from Apollo Proton Center also joining us. So we are truly multicentric. And I will now conclude. Elective whole pelvic RT is definitely needed. It should be the standard of care based on POP-RT for high risk and very high risk patients. All the patients who have a lymph node risk more than 20%. It comes at a cost of slightly increased bladder toxicity. It is possibly needed even when you do SBRT, and 25 in 5 seems to be safe, and we should use PET hopefully to optimize treatment for node positive disease. Thank you so much.
Thank you so much, sir.
If I can ask, you don't have DFS or OS as your secondary endpoint in the PRIME trial. So
yes, we have.
Okay, fine. So you just mentioned in your slide about QL, toxicity.
No, there is DFS.
Oh, great, fantastic. Great, thank you.
Thank you so much, Vedang sir. And now moving forward, I would like to invite Dr. Kaustubh Talpatra, Director Radiation Oncology, Nanavati Max Super Speciality Hospital, Mumbai. And sir is going to take us through the neoadjuvant and adjuvant role of ADT in prostate cancer. So over to you, Kaustubh sir.
Yeah, one sec. Something is not right here. One sec. I'm not getting my... One sec, Mithali. Just give me a moment, Mithali.
Yes, sir.
I'm happy to take any questions if you have.
Vedant, I just had one question. So, looking at the radiobiology, the thing is, you're giving the same dose to the pelvis, whether it's, in elective, you got both high risk, very high risk, as well as the node positive. So the thing
You're
is,
talking of prime?
Yeah, prime. So I believe you're giving the same dose for someone, in the elective, and the same dose someone who's got node positive. So in the node positive, is the dose higher, the boost?
Yeah. So what we are doing is we are in the prime trial protocol, anybody who has a residual node of anything more than a centimeter is given a boost after the 3 to 6 months of ADT. Everybody gets a boost. The prophylactic region, microscopic disease, gets 25.
Fine. So shall I start, Mithali? Mithali?
Yes, sir. Yes, sir. Yes, sir. Over to you, sir.
So I'll be talking about neoadjuvant and adjuvant hormone therapy, ADT, with radiotherapy in the setting of prostate cancer. I will be brief. It is important because hormone therapy is something which we are often confused, where it's required, where it is not required. And I will put in certain perspectives in place where it is required. Now, this is a dashboard. And if I may say, is there a role of ADT currently in terms of evidence in newly diagnosed localized prostate cancer? Answer is probably yes. Newly diagnosed locally advanced prostate cancer? Answer is definitely yes. In localized rising PSA, biochemical therapy after biochemical failure after local therapy? Answer is yes. Non-metastatic castrate-resistant prostate cancer, rising PSA, the answer is yes. So let us run through the trials. The way we had designed this program, we wanted the evidence to come through, and finally a take-home message, which Rohit will be percolating in the end. So let us look at the evidence of neoadjuvant ADT with RT. Two important trials. One is RTOG 8610 and the other one is 9601, TROG 9601. So what did RTOG 8610 do? It randomized locally advanced prostate cancer, non-metastatic, 1:1. One arm was radiotherapy alone. The other arm was goserelin and flutamide with radiotherapy. The total treatment duration of that arm was hormone therapy was for 2 months. That is total treatment duration of 112 days. The primary endpoint was loco-regional control. What did TROG 9601 do? It had 2 arms. Apart from a radiotherapy only arm, it had a 3-month neoadjuvant goserelin and flutamide arm and also a 6 months arm. The primary endpoint again was time to local failure and prostate cancer specific survival. The results, RTOG 8610, at 10 years, the arm which had goserelin and flutamide with radiotherapy, there had been less patients who had died at 10 years as compared to the RT alone arm, which was statistically significant. So they basically looked at the disease-specific mortality. Similarly, in TROG, the prostate cancer-specific mortality, the results were best and the mortality was least in the 6 months arm, which was statistically significant, but not the 3 months arm. This is talking about the overall survival. If you look at RTOG 8610, there was a trend towards a better overall survival, but it did not reach statistical significance. And in TROG 9601, all-cause mortality, the 6 months arm, if you see the hazard ratio, it was 0.63 and it was leftwards of the unity. This was a setting where we had talked about neoadjuvant hormone therapy with radiotherapy. Now let us look at what is the evidence of adjuvant hormone therapy, that is adjuvant ADT to radiation therapy in high-risk localized and locally advanced prostate cancer. So There were URTC22863, RTOG8531, and DM-ECOS trial. All of them showed improvement in survival after adding ADT to radiation therapy. This is the RTOG8531 graph, and I'll be talking about the meta-analysis. You have a meta-analysis by Emilio Bria. This is the forest plot of the overall survival, and you can clearly see the statistic. It is statistically significant, and the relative risk is 0.86. It's towards the left of unity, which favors ADT and RT as compared to RT alone. It is clear that adding adjuvant therapy to radiation therapy is better than doing radiation therapy alone in a subgroup of patients who are locally advanced prostate cancer. And these trials also included patients who were localized prostate cancer. Duration, this is a study by A. Nabid et al., which had shown androgen deprivation therapy in this setting for 18 months versus 36 months. And in this particular trial, 36 months did not do better or worse than the 18-month setting. Now, talking about, so we have seen two settings, neoadjuvant therapy to radiation, adjuvant therapy to radiation. Now let us look at the evidence of adjuvant hormone therapy with radiotherapy after radical prostatectomy. And I do not need to speak much because Vivek has talked a lot about this trial, and definitely there is a benefit in 10-year progression-free survival in the patients who received goserelin plus radiotherapy after radical prostatectomy. This trial has been discussed in detail. With all this, when benefits of adding hormone therapy was being discussed with radiotherapy, a group thought, is radiotherapy really necessary? Can we omit radiation therapy? And this is Widmark's trial, that is SPCG7, which showed that omitting radiotherapy did not really help patients, and the results were much worse as compared to ADT alone. So radiation therapy is necessary. So even in MRC PRO7 trial, 1205 patients, which has clearly shown that overall survival as well as incidence of metastasis, incidence of failure in both aspects, the group which received ADT and radiation did and fared much better than the group which received ADT alone. I'm just skipping some slides. I think. So this I don't know, these slides are repeating. 1 second. Yeah. So we have discussed few settings now: neoadjuvant with radiation, adjuvant with radiation, adjuvant hormone therapy with radiation after radical prostatectomy. Just a word about, is neoadjuvant hormone therapy required in a pure radical prostatectomy setting where there is no radiation? And the answer is no. All the trials have failed. The neoadjuvant hormone therapy has not shown a benefit in radical prostatectomy setting, and most of the trials have shown whether the disease-free survival or overall survival, they are similar, whether you add neoadjuvant hormone therapy or you do not add neoadjuvant hormone therapy. Few questions Rohit will answer. I'm pushing everything on to Rohit, but yeah, one or two I will answer. LHRS agonist or antagonist? Antagonists like degarelix, they cause less flare. So which are the settings where you consider antagonist? There are flare settings, impending cord compression, cardiac abnormality. Those are the settings where you would consider antagonist. Otherwise, generally you tend to consider agonist. Which drug to choose? I'll be talking about that. And duration of therapy, I'll be talking about that. So duration of therapy, this is hormone therapy of 2 months before radiation, 2 months after radiation. EORTC 22863. which was 3 years of duration of ADT, and RTOG 8531, the duration of ADT was indefinite. And you can see progression-free survival is in this setting is to the tune of 35%, and here it is to the tune of 30%. Whereas in a short course hormone therapy, the disease-specific mortality is 36% and biochemical failure is 80%. But if you go through the guidelines, typically they propose a hormone therapy duration of 2 to 3 years currently. Which drug? Goserelin has clinical data across all the 3 prostate cancer settings, that is localized, locally advanced, and metastatic, and that is the most widely used drug currently. Thank you. So again, just to summarize what we have talked about, in locally advanced prostate cancer, neoadjuvant and adjuvant hormone therapy, both are important. Before radical prostatectomy, do you benefit from hormone therapy? Answer is no. In a post-radical prostatectomy setting, do you combine hormone therapy with radiation? Answer is yes. When do you select agonist versus antagonist? Antagonist you select in flare situations. What is the duration? Typically recommendation duration are 2 to 3 years, although there is evidence for indefinite hormone therapy also. And which is the best drug? The most evidenced drug is currently, and the widely used drug is Goserelin. Thank you for the patient hearing.
Thank you so much, Kaustubh sir. And now we shall move forward to the panel discussion. So I would like to invite Chairperson Dr. Sandeep D, Senior Consultant Radiation Oncologist, Apollo Hospital, Mumbai. And for the case study moderation.
Mitali, I'm so sorry. Oh, so sorry.
No problem, sir.
We would like the chairpersons, Dr. Srivastava and Dr. Sona, just give a concluding remark for this session. It was an important session, I think, and they should give a concluding remarks if they're still here before we move on to the next session.
I think Sonali ma'am is there. Dr. Srivastava is also there, sir.
Yeah, please ask them to give a concluding remark.
Requesting Dr. S.K. Srivastava and Dr. Sonali Pingle ma'am to give a few words for the concluding remarks, ma'am.
Pingle, my senior.
Sonali ma'am.
Hello, can you hear me?
Yeah, yes, sir, we can hear you.
Yeah. Kaustubh, congratulations and thank you very much. It was really a wonderful session. I mean, to begin with the whole concept of hypofractionation, followed by Vedang has given for the nodal radiation. So it has been very, very useful. And I'm sure all the PG students and the consultants would have enjoyed it. And Kaustubh, again, I would like to really congratulate, and I hope you will conduct even many more meetings like this. It has been very, very useful. Thank you.
Thank you, sir. Thank you. Dr. Sonali is there.
Hello, can you hear me?
Yes, Sonali. Yes,
yes, ma'am. We can hear you, ma'am.
Yeah, very well conducted session. It was really useful. And like sir said, not only for the PG students, I think we also learned quite a bit about when to use radiation, when to use only prostate RT. So thank you.
Mithali, I think you can hand over the next session to Dr. Tungaonkar and Dr. Sandeep De.
Yes, sir. So I would like to invite Dr. Sandeep De, Senior Consultant Radiation Oncologist, Apollo Hospital, Mumbai. And for the case panel discussion moderation, I would like to invite Dr. Srinivas Chilikuri, senior
Sir is not there. Dr. Tongaonkar is not there, Mithali.
No, sir is not there. I just checked. Yes, sir. So for the case study moderation, I would like to invite Dr. Srinivas Chilikuri, Senior Consultant Radiation Oncologist, Apollo Proton Cancer Center, Chennai. And for the panelist, I would like to invite Dr. Santosh Vaigankar, Consultant Uro-Oncologist and Robotic Surgeon, Kokilabem Dhirubhai Ambani Hospital, Mumbai. Dr. Mukul Roy, Consultant Radiation Oncologist, Jaslok Hospital and Research Center, Mumbai. Dr. Dipanjali Adulkar, Consultant Radiation Oncologist at CG, Mumbai. Dr. Shivam Shingla, Consultant Medical Oncologist, SL Raheja Fortis Hospital, Mumbai. And Dr. Roshan Kumar Patil, Consultant Radiation Oncologist, HCG Manavata Cancer Center, Nashik. Over to you, Srinivasa. Srinivasa, we can see your slides, but we can't hear you, sir.
Hello, hi, good evening.
Good evening, sir.
Yes, good evening, everyone. We had a very excellent session so far. I mean, this is an opportunity for us to kind of reiterate what we have learned so far and probably take home some message from this symposium. So what we have learned is regarding the moderate and extreme hypofractionation, when to use it. Let's discuss when not to use it, especially regarding extreme hypofractionation, or should we do whole pelvic RT as suggested by Dr. Vedang? Should we be doing ADT? For how long? What's the duration? What kind of ADT? All that will be discussed in the next few slides. In the next few questions, we'll discuss all these pertinent issues. So let me start with the first case. He's a 45-year-old gentleman who came to us with mild urinary symptoms, underwent a PSA, which was 8.85 nanogram per ml. The digital rectal examination showed a hard enlarged prostate, about 5 by 3 by 4 centimeter size. Not very bulky, but slightly bulky. MRI showed a Pyrat's 5 lesion in the right peripheral zone with loss of fat planes with seminal vesicles. And the biopsy revealed 6 out of 12 cores were positive for acinar adenocarcinoma. And of course, from different cores, different Gleason grade groups were reported, ranging from grade group 3 to grade group 5. Obviously, we'll take the worst group. One core had group 5, Gleason grade group 5 component. So it was staged as grade group 5 prostate cancer with 4+5, Gleason 9. PSMA PET scan was also done, which is kind of routine for us now, standard for us now rather. It showed a localized lesion, which did not involve seminal vesicle. Although I have not seen the scan myself, this is what the report says: the fat planes with rectum were ill-defined. So essentially, I think let's take a perspective from our panelists. I think our panelists, welcome to all my panelists today. I have 2 urologists, 2 radiation oncologists, and 1 medical oncologist, if I'm not wrong. And let's start with Dr. Santosh. How would you treat this patient? What is your view on this?
Dr. Srinivas, first of all, thank you for including me in the panel. And I'd like to know, what about the DRE findings? What about the rectum? Has anything been mentioned about it?
Nothing.
Nothing. Okay. So this
MRI doesn't show anything in the rectum or perirectal area. So there is nothing will stop you from suggesting surgery, I'm sure.
Yeah, MRI tends to sometimes over show things. So we base our findings on DRE as well. Right. So this patient would be a high risk case, definitely. So I would give him both the options, surgery, as well as I would also ask my radiation oncologist to ask my patient to also visit a radiation oncologist for his perspective. but this will definitely be a multimodality therapy. And with respect to that, the counseling would be done.
So based on this, would you consider T3B and MRI? Sometimes there's a discrepancy between MRI and PSMA PET. And you mentioned that MRI tend to overestimate sometimes.
Yes.
So you would rely more on PET or MRI? What do you think?
No, MRI, on MRI.
MRI, localized. Completely agree with you.
Yeah.
Great. So I think we have another urologist as well in the panel. Kaustav?
No, Srinivas.
No, sir.
Only urologist. Dr. Hemant sir is not there.
Okay. And
he's supposed to chair the session. He is not there.
Okay. So, and I think it would be a standard surgical approach. I mean, what would be your surgical approach, Dr. Santosh?
It would be wide excision in a sense. Usually when it is localized, it's not T3B. We usually tend to go in between the two layers of dental fascia, but here we'll go below both the layers of and preferably focus on wide excision. We are not going to think about.
So you would do that surgery robotically, I assume?
Yes.
Of course. And you would dissect the nodes as well?
Yes.
Systematic nodal dissection. Okay.
Yes.
So that is fine. That is a surgeon's view, which is completely justified. The radiation oncologists in the panel, one of you could, the panelists are, Dr. Deepanjali is one. So Dr. Deepanjali, you can start taking this question if you don't mind. What would be your preferred treatment for this patient?
Sir, so if I have to stage this patient would be CT3B, N0, M0, Gleason score 4+5. So it will be a high risk CA prostate. So for this patient, I would initially start with the neoadjuvant. I would give him the option of surgery versus neoadjuvant hormonal therapy followed by radiation.
Okay. I mean, true to yourself, I mean, you started with neoadjuvant ADT, but later on you said surgery also. But don't worry, I'm asking a radiation oncologist, what would be your preference? So you said neoadjuvant ADT followed by RT, is that right?
Yes, neoadjuvant ADT followed by RT.
Okay, fantastic. So say, why would you not subject this patient to surgery?
Considering that this patient has loss of fat plane with seminal vesicle, which is a T3B, invariably this patient would have required post-op RT because it would be seminal vesicle positive. So instead of going for two modalities, I would prefer the patient to go for a single modality.
Fantastic. Okay, I agree. I mean, I understand your point. Anybody else, the radiation oncologist? We have only one radiation oncologist.
No, we Srinivas, we have Roshan and we have Mukul Roy. We have three radiation oncologists.
Sorry, I'm sorry. Dr. Mukul.
Yeah. Hi.
So you have heard of Dr. Kaustav speak, and yes. What is the ADT? What is the ADT and what is the duration of ADT here?
So perhaps I would go for maybe 3 to 6 months of ADT for this patient.
So the reason I mean, just to bring a slight context to this discussion is that we have all discussed various aspects of prostate cancer radiotherapy, but this is for a grade group 5 prostate cancer, which is probably the most aggressive subtype. So would you have a different preference based on histopathology is the question. So coming back to ADT and duration, you said, sorry?
Yeah, I said perhaps for a duration of 3 to 6 months of ADT.
Okay, and then?
And then I agree with Dr. Deepanjali. I would take up this patient for external beam EBRT.
Okay, and you would treat pelvic nodes as well?
I think the nodes are negative in this patient, right?
Yes.
So I would not treat the pelvic nodes. for this patient.
Okay. Srinivas, can I just barge in and play a devil's advocate here since we are having such a lovely discussion? And Santosh is here, Santosh Vaigankar. I had a question. Is it okay, Srinivas? Can I just ask a question?
Go ahead.
Yeah. So we keep talking about the moment it's seminal vesicle invaded or invasion is present, it is only radiation. That's the concept that's being taught to us since our MD days. Whereas if you go through the changing guidelines over the last 6 to 7 years, surgery or a multimodality treatment has also become a standard approach in a Gleason grade group 5. When you speak to surgeons, they say removing seminal vesicle is not a big deal for us. And in oral cavity also, you are doing dual modality treatment and you are enhancing survival. So where is the problem? So Santosh, what is your take on it?
I completely agree with you, sir. In fact, I wanted to ask one question, whether seminal vesicle biopsy was done. I think it was not done. And as I said, seminal vesicle, to take care of seminal vesicle during surgery is not an issue because we haven't found any clinical scenario where the seminal vesicles are hard or they might be shrunken, but it is taking them off, surgically removing them off during a radical prostatectomy in this scenario should not be a problem. That's what I feel, sir. And you are absolutely right what you said.
Srinivas, do you agree to this, Srinivas?
Yeah, absolutely. I mean, seminal vesicle involvement or not is not a contraindication or indication for surgery. Only the point which Deepanjali mentioned is the patient, if the patient has a Gleason grade group 5 prostate cancer, and if the patient has seminal vesicle involvement, which is a T3B disease. So as she pointed out, surgery ideally should be followed up by a post-operative radiation therapy treatment, which is like an elective thing rather than more of a early salvage, which we can offer routinely. So that is a point which I would also, although I would say that surgery is still an option in this particular patient, but I would prefer radiation. I would try to convince the patient that the patient could be better off only with ADT and radiation therapy. But let's come back to Dr. Roy's statement that she doesn't want to treat pelvic nodal RT. Can you elaborate on that, please?
Hello.
Hello.
Hello, this is Roshan, Dr. Roshan.
Dr. Roshan, do you agree with that?
So I will treat the pelvic lymph node because as it is a high-risk patient, my dose fractionation will be moderate hypofractionation like 68 gray and 25 fraction with pelvic lymph nodal radiation to a dose of 50 gray 25 fraction.
So the point is, I think Dr. Vedang showed clearly in his slides very beautifully that in patients who are pelvic node negative also benefit significantly with, in fact, those are the patients who really benefit from elective pelvic nodal radiation.
Yes.
So let us, I think, follow what the evidence clearly shows.
Yes.
And I think one should consider treating pelvic lymph nodes in this particular situation.
Yes, sir.
Especially in a patient who has a Gleason grade group 5 prostate.
5. Yes, sir.
Dose and fractionation. Of course, it is very easy question to radiation oncologists. Everyone would say moderate hypofractionation. But does anyone like to practice extreme hypofractionation or in this particular patient in a high risk situation? Dr. Deepanjali?
Sir, so for this patient, the treatment would be neoadjuvant hormonal therapy followed by radiation followed by adjuvant radiotherapy.
That is fine.
Adjuvant hormonal therapy.
No,
now, with
I'm
respect
asking
to
about
dose and fraction.
Yes.
Dose and fractionation for this patient. This is a young patient, 45 years old. I would obviously there are two options about moderate fractionation and extreme fractionation. Currently, we have evidence for moderate fractionation, and I would, because since it's a very young patient, 45 years old, I would go for for moderate hypofractionation in this patient. If it was an elderly patient wherein treatment time or treatment duration would have been a very important factor, in that patient, I would have definitely considered extreme hypofractionation.
So fantastic. So what you mentioned is a very important point, that, you know, by making it extreme hypofractionation, we are essentially not improving the outcomes in terms of, you know, benefiting the patient in terms of better disease outcomes, but we are only benefiting in terms of time, treatment duration. So if that is not a major concern in a very young patient who is especially in high risk patients, I would also prefer moderate hypofractionation till extreme hypofractionation becomes the standard of care. And that is why we have this PRIME trial, which will answer hopefully whether we can safely do this extreme hypofractionation. Until that is out, I think the way forward is to practice moderate hypofractionation in high-risk prostate cancers as a standard. So to Dr. Shivam Singla, I'm sorry to if you are feeling left out.
Sir, I'm enjoying the conversation.
I also wanted your view. What is your preference?
So, sir, in my practice, I offer these patients neoadjuvant hormone therapy. And then I'm very happy to send these patients to surgeons for role of robotic surgery. And if the surgeon says no, then of course, then the radiation oncology colleagues take care of the...
So that is a very interesting point which you raised, which is a total Pandora's box. Because if you have given neoadjuvant hormone therapy, surgery is not the standard after neoadjuvant hormone therapy, as you know. So Dr. Santosh, coming back to you, Dr. Shivam raised an important point. Although a lot of urologists do it, there is no evidence for it. But what do you think of it?
I'm not completely against it, though I don't practice it, but it is definitely something which we have to look into the future. It has been practiced. There are case reports, and it's high time that it will come into the evidence guidelines as well.
Okay. So only in what kind of patients? I mean, in a bulky prostates?
So in prostates which have got a high tumor load, I mean, it's all core positive, 5+5 or something like this. And on PR, if we find somewhere that the rectum is not mobile at one point, or if as you said, bulky prostate, huge prostates, these are the cases who probably, you know, ADT would be given.
So Dr. Singla, and to all the people in the audience, whatever Dr. Santosh mentioned is absolutely his opinion and what many urologists practice, but I don't think it is a standard, standard guideline based recommendation. So that is a personal preference, I'm sure. We will keep it that way. But essentially, for all of you to understand, neoadjuvant hormone therapy is usually followed by a radiation therapy, which is standard. So let's give this message to all the medical oncologists.
Can I just come in, Srinivas? I just had a comment about this. Is it okay?
Yes.
I'm not a panelist. I can. Hello.
Please. Yes, please.
Yeah. So, Santosh, I see your point. You may not be against it, or it is done, etc., etc.
Yes, sir.
But we have to understand that this can have an effect. If you give about 6 months of ADT before surgery, the testosterone will not recover for another 6 months, may not. And that will have an effect on your observation.
True, sir.
If you are a proponent for giving, or you're okay with giving NAHT also, and you strongly prefer salvage also, then you can't have your cake and eat it too.
So Dr. Vedang, I am.
So that's the reason why
I'm coming to that question specifically later on. That if only if, whenever
Chillikuri, just one point I wanted to mention is that's the reason why I specifically mentioned Murthy sir. I don't practice it.
No,
but
I understand.
This is exactly the reason why I'm not in favor of it. So, but since I was asked the question, I just give an answer.
No, Santosh, nothing against you or your practice. I just want the audience to understand that if ADT has been given before surgery, then one must insist on
adjuvant
rather than waiting for salvage, because the histology may vary, the PSA kinetics may vary, so these things will happen. That's
absolutely, sir.
And it is, I think we have seen, all of us have seen many times this happening quite often, and then patient looking for PSAs, because PSA is normal, radiation is not recommended. So I think it's an important message which everyone must understand, that whenever patient receives neoadjuvant hormone therapy before surgery, patient is unfortunately or fortunately becomes a candidate for adjuvant postoperative radiation. So any role for abiraterone or enzalutamide, Dr. Shiva?
No, sir. Not at all. I mean, post-RT adjuvant therapy, but no role for NHA at this moment.
Okay. So total duration of 18 to 24 months of ADT and RT, that is what the consensus is, right?
Yes, sir. Yeah.
Okay. So, I mean, I wanted to bring these slides just to showcase another aspect, apart from the fractionation, apart from the nodal talk, apart from the salvage versus adjuvant, and then hormone therapy. What essentially is important is in Gleason grade group 5, these are rare tumors. I mean, not rare. I mean, they are not very common tumors, but they are not very uncommon as well. And what has been shown is, just because it's a higher grade malignancy, people talk about multimodality treatment very often. Yes, it is an option, surgery followed by all the adjuvants or salvage treatments, but radiation alone, along with ADT, appropriate duration of ADT leads to good outcomes. This is what this article, the retrospective study, but it clearly shows that there is a benefit of adding. Results with radiation plus ADT are quite reasonably good. Similarly, this is another paper which actually did a larger group of patients, which also showed that patients who undergo radiotherapy or radiotherapy plus brachytherapy have in fact slightly better outcomes compared to those who undergo radical prostatectomy followed by adjuvant treatment. So essentially, whatever we know, maybe this also is retrospective and this also could be biased, as are all the initial studies which have shown that in grade group 5 or aggressive prostate cancers, multimodality treatment is the way forward. So this is what the message I want to take, a message I want to give to everyone, that even in aggressive prostate cancers, RP is, radiation plus ADT gives a reasonably good outcomes. Also, newer hormonal agents, which we have talked about, the one which, in this particular patient, which is, he's actually a T3B disease patient, the T3B-N0, and a Gleason grade group 5. So based on the recently published Stampede platform protocol, which is a pooled analysis of meta-analysis of 2 different trials, clearly showed that there is a benefit of addition of 2 years of abiraterone to ADT in patients such as these, either node positive patients or 2 of the 3 following risk factors, either grade group 5 prostate cancer, PSA more than 40, or T3A or T3 or T4 disease. So essentially this patient fits into this category, and this patient also may benefit. Whether you do it or not is a question which we'll all have to answer later, but probably this, based on this protocol, again, this is a randomized evidence, one could consider addition of abiraterone in this particular patient also. So what actually happened was, this patient underwent radical prostatectomy. HPR showed that it was indeed Gleason grade group 5. The pattern 5 was 10%, pattern 4 was 70%, pattern 3 was 20%. There was non-focal extraprostatic extension with pattern 4. Perineural invasion was present. Right-sided seminal neurovascular bundle was involved. Lymphovascular emboli was present. Right seminal vesicle was involved, as was shown on the MR. The left SV was uninvolved. All surgical margins were negative. But surprisingly, it showed right obturator nodes, 2 out of 4 nodes involved, left obturator, 1 out of 3 nodes involved, and rest of the pelvic nodes were negative. So this is also another lesson that PSMA PET negativity, and somebody also mentioned that they will not treat lymph nodes, would not be a very good idea in this particular situation, because PSMA PET is not extremely sensitive. Sensitivity of PSMA PET to pick up pelvic nodes is only 40%. The specificity is very high, but the sensitivity is not very, very high. So based on this now, would Dr. Santosh, when would you assess post-op PSA, and when would you take a decision regarding adjuvant or salvage? And do you have any preference in this particular patient?
I would.
We'll have to wrap up in 5 minutes. Sorry to interrupt. We'll have to wrap up in next 5 to 7 minutes.
Okay. So, Dr. Srinivas, I would be doing the PSA at the end of a month after surgery. Okay. And with the histopathology, what's the PSA? Is the PSA recorded?
8.8 the beginning. Index PSA was 8.8.
After surgery?
It was, I don't remember it now, but I think it was undetectable.
Okay. So, but even with that report, with the report that you have flashed on the screen, yes, I'll probably go for an adjuvant. I'll probably get my radiation colleagues involved here.
Fantastic. So because it is a high-risk patient, as multiple risk factors, so you would prefer an adjuvant rather than a salvage approach.
Yes, absolutely.
I hope all the radiation oncologists agree with this. Dr. Deepanjali, Dr. Roy, and
yes, sir.
Dr. Patil,
yes,
you would agree with it. So adjuvant radiation, although early salvage radiation was shown to be as good, or in fact even better in terms of toxicity, adjuvant radiation can be considered and probably should be considered in high-risk patients, especially those with multiple risk factors, especially T3, T4 disease, node positive, definitely yes, and with higher Gleason grade group patients. So if adjuvant needed, Deepanjali, when would you treat? Would you treat pelvic nodes? What is your dose and schedule? What is your preference?
So I would like to assess the patient post-operatively, whether he has any post-op urinary symptoms, and
that every patient will have. So when would you like? Every patient will have some urinary symptoms. What urinary symptoms you are looking for?
So generally would assess on the IPSS score for urinary symptoms. If it is a mild IPSS, I would go ahead with RT post-op 2 months when the patient is completely recovered. And if it is a severe, I would start off with ADT and then assess the patient after 2 to 4 months and give him adjuvant radiotherapy. Now, regarding the volumes, I would include the pelvic nodes as well as the post-op tumor bed. And the dose would be around 66 gray in 33 fraction for a post-op prostate cancer.
Okay. Dr. Patil, would you agree with what Dr. Deepanjali said, or would you?
Yes, sir, absolutely. Basically, especially if the patient is having urinary incontinence, then we will wait for adjuvant radiation. In between, we can start ADT. So as far as dose is concerned, adjuvant radiation, I would like to give around 64 to 66 gray in normal fractionation.
Okay. Dr. Mukul Roy, you agree with it? Dr. Santosh, I mean, would you agree with radiation oncology colleagues 2 months is a good time to irradiate?
Basically, it depends on how quickly has recovered his continence as well.
Correct.
So that is something which I will be looking at.
So typically, what is the time duration for the recovery of continence as per your experience?
So if you talk about this patient who's got an extensive excision and if the anastomosis is good, there's no post-op complications, then usually by 3 months, 3 to 6 months would be a time when we should be able to have reasonable continence, or he should be at least on one pad a day, one pad a day. Yeah.
Okay, so basically only stress incontinence, would you say normal, the leaks would come down and only stress incontinence there would be the best time?
Yes, because mostly what we have seen is even if the patient says it's one pad a day, it's more of psychological. And if we push the patient, even that pad is not used.
Right.
So that's the reason why we take that as a cutoff.
So radiation oncologists in the audience, the sweet spot is generally usually after 3 months. Before 3 months, I mean, one could give it, but before 3 months usually is associated with worsening of incontinence. So I would wait for 3 months at least, and if not more. And waiting for 4 or 6 months is also not a bad idea, but at least for 3 months till the recovery of full continence. Only patient will be complaining of occasional stress leaks. If that is a situation, that would be the best time to intervene. So pelvic nodal RT, you mentioned, there is a role for pelvic nodal RT. Obviously, in this patient, you would include. Pelvic nodal RT is also another question which is being answered by the RTOG, which is already presented but not yet published, the SPPORT RTOG trial, which showed that there is a benefit of adding the pelvic volume to the prostatic bed. So based on what the surgeon showed us, Dr. Venkatramani showed us, would you add ADT as well, Dr. Deepanjali?
Yes, sir. For this patient, definitely.
For how long? That is a question. Would you add, as per French trial, AFU16, 6 months?
No, this patient would be a high-risk patient, so it would be for 2 years total.
Fantastic. So you would give for 2-year duration?
Yes.
Okay. So that's a question which I wanted to ask Dr. Santosh is, in case adjuvant ADT started, problem is also when we see patients referred by urologists when they already start adjuvant ADT immediately after surgery, when they know that it is high risk probably.
Yes.
So, I mean, you would start only if adjuvant RT is being planned, right?
See, to be very frank, with this patient in mind, I would involve my medical oncology colleagues here. Yes. The reason why I'm mentioning is that I want this team to work with him because I don't know how the patient would fare in future. So I want a medical oncologist to be a part of the treatment modality.
Yes.
So yes, you're right. We get patients who have been started on ADT because they consider lymph node positive as a systemic disease. And that's the reason why ADT is started. And that's what the patient has been explained. Yeah. So I guess...
sorry, go ahead.
So I guess ADT should be started.
Okay. And Dr. Singla, would you add NHS now? The same patient?
Yeah, sir. This is a high risk nodal disease. Such patients you've also shown. Yeah, I would add abiraterone adjuvant also along with ADT with high nodal burden, sir. I think this patient may benefit.
Yeah. So that is the reason why probably even in the upfront setting, when we would not operate this patient would have benefited with abiraterone, especially because he's a aggressive disease grade BSIM grade group 5. Also, another thing which we all have to understand is there are two unique aspects to this case. One is the patient was very young, 45 years, which I don't know how many of you have specifically noticed. I'm sure Dr. Santosh would have noticed because it would make his life easy. His continence would recover faster and everything else. We do not have data regarding younger patients doing better with surgery or radiation. We do not have that data. Although we have data that younger patients tend to do better than elderly patients, very elderly patients. But there is a role for germline testing. So Dr. Santosh, would you recommend as a routine for all patients younger than 60 or 55 to undergo this germline testing?
Yes, I would.
Yeah. And so you would counsel this patient yourself, or you would send to somebody, oncologist, medical oncologist?
Yeah, so for when I would definitely make a mention of the test being done and the reason for it, but the pre-test and post-test counseling are done by experts, not by me.
So what is the germline testing? You will test for only BRCA or something else as well?
No, it will be a larger panel testing.
Okay. Okay. Dr. Singla, any comment about the germline testing?
Sir, as of now, we are suggesting germline testing for all high-risk node positive or all high-risk patients. Sir. NCCN guidelines recommend germline testing for all patients who are high-risk or node positive.
Srinivas, I'm sorry to interrupt, but I think we have overshot the time. We'll have to conclude it in a minute or two.
So the next slide is the conclusion, which is...
Oh, great. That is great, Srinivas. Okay.
So I think I wanted to put few things in the conclusion slide, but I heard Rohit is going to conclude everything. So over to you, Rohit.
No, you can put a quick remark. You can always put Srinivas. That's not a problem.
No, that's fine. I think I would like to thank all the panelists for the evening for their participation.
Thank you, Dr. Srinivas. So before we conclude, I would request Dr. Sandeep Day, if any comments, sir, you would like to present from your end for the case discussion that we have done.
No comments specific, but well conducted, Srinivas, as usual. But the only thing I just want to make a point is that, not pertaining to this particular case, what you discussed is that for men who are having a PSA only recurrence, following radical prostatectomy, salvage prostate bed radiation therapy is still now is a grade 1B recommendation. The RTOG trial is definitely looking into adding radiation to the nodes, but that still needs to be looked into.
Yes.
What do you?
I agree with you, but the problem is, see, radical prostatectomy, if it is done for a low and intermediate risk patients, usually which is quite standard everywhere. If that is done, definitely, a role for pelvic nodal RT is still being evaluated or studied. And the study showed, the RTOG study actually showed that there is a benefit of adding pelvic nodal irradiation in terms of metastasis-free survival. So one could consider that in a situation where the pre-RP probability of nodal mets was high. But, or if the pre-SRT, which is pre-salvage radiation therapy PSA is high. So in these two situations, one could consider pelvic nodal RT. If not, prostatic bed is perfectly fine. But in this patient, when we are irradiating after...
I'm not telling pertaining to this case. That's what I told in the beginning. Yeah.
This patient is, I think, exceptional because...
Yeah.
Yeah.
So many factors, the multiple adverse prognostic factors are there.
Correct.
Thank you, Kaustubh and the organizing committee.
Thank you, sir. Now I would like to invite Dr. Rohit Malde, consultant radiation oncologist, Nanavati Max Super Speciality Hospital, Mumbai, to give us the concluding remark and the echo message. Over to you, sir. Sir, your slides are visible, but we are not able to hear you, sir.
I think it's on mute. Okay, now I'm audible?
Yes, sir.
Great, fine. So fine. So I'll just summarize all the topics that we've discussed. So I think Thiruranjan Basu gave an excellent presentation on hypofractionation. So basically, I would recommend the ASTRO-ESCO and AUA guidelines, which were published in the Red Journal. So this is a very, very important publication, which PG students could go through. So just to summarize, the thing is, just as in breast cancer, we've got hypofractionation, which is now the standard of care. I think it's reasonable to say that in prostate cancer as well, moderate hypofractionation is now the new, standard of care, as it confers similar prostate cancer outcomes, similar rate of late toxicity, and acceptable slight excess in acute GI toxicity, which is manageable. And the commonest and most favored regime is the is the 60 gray in 20 fraction in 4 weeks as per the CHIP protocol, where the prostate only is to be treated. But in the high risk and very high risk, where you want to treat the lymph nodes as well, I think, the POP trial where you use 68 gray and 25 fraction is also welcome, is also an acceptable regime. So in moderate hypofractionation, what we are looking at is somewhere between 240 to 340 centigrade per day. So this recommendation is across all the risk groups, whether it's low risk, intermediate unfavorable, intermediate favorable, high risk or very high risk, where conventional RT is indicated, and it is irrespective of age, comorbidity, anatomy, or baseline urinary function. The ultra hypofractionation is when we're talking of at least more than 5 gray per fraction or more. So here the thing is the recommendation is conditional. There we have got 2 trials which have completed accrual, 2 are still accruing. So I would say that ultra hypofractionation can be offered in select low intermediate risk groups in the hands of experienced personnel in a high volume center, who have got very extremely trained professionals who can do that very, very safely. It is reasonable to do that. I would say for high risk and very high risk, it would be best to recommend enrollment into the clinical trials, which I think Vedang is doing at the Tata Memorial Hospital. So the second topic was dealt by was Vedang, where he very beautifully illustrated the role of elective nodal irradiation in prostate cancer. So here the gist is basically we need to know our Partin tables, get the Roche formula, or maybe use the risk groups, which is now in the NCCN guidelines. And the whole idea is to try and get a feel or estimate of the risk of lymph node involvement. So Vedang talked about a few of the initial trials, the RTOG trial and the GETUC-01 trial. And the thing is, here essentially the risk of lymph node metastasis was not too high. It was estimated to be between 15 to 20%. And that is why in intermediate risk groups, there is no role of adding elective nodal irradiation, as there was no major impact on the prostate cancer outcomes. And, these were, it did not make a difference. But whereas we look at the high risk or the very high risk group, where the risk is very, very high, more than 20, it could be as high as 50% or so. So here, there is certainly a benefit in the prostate cancer outcomes. So what Vedang has used in his clinical trial in 224 patients is 68 gray in 25 fractions, given to the prostate, and 50 gray in 25 fractions given to the pelvis. And we should involve the lymph node volumes up to the common iliacs. So here, all these patients received 2 years of ADT as well. So that is important. So they've got a good, reasonable, median follow-up of over 5 years. And certainly the soft point which Vivek talked about, the biochemical free survival, there is significant 14% impact in that. But not only that, the secondary outcome, which was DFS, is also significant. So that is also approximately around 7 to 8%. However, there is no difference in overall survival. But Vedang does expect with more sort of 3 to 4 years of follow-up, once we've got the 10-year data, there may be a difference. But we await to see that. The acute toxicity, the thing is there is no major difference. The slight concern with the grade 2 GU toxicity, which Vedang mentioned about, which is high, 20%, whereas the GI toxicity is not a major concern. Then we had this topic on early salvage radiotherapy treatment by Kinjal, as well as the hormonal aspect thing as well. So here the thing is, there is a pivotal meta-analysis of meta-analysis where, the trend, internationally is to try and push for salvage radiotherapy treatment versus adjuvant. So this particular, meta-analysis is published in October 2020. I would urge the PG students to go through this. So, here the thing is, the buzzword is, use it for salvage radiotherapy for patients with reliable follow-up. The timing of RT is use it as early as possible, and preferably when the PSA is less than 0.5, where the outcomes are much better compared to if the PSA is more than 0.5. There are nomograms available to predict the 5-year biochemical free survival, and where you could estimate your benefit, and it's based on the Gleason score, the margins, and the PSA at the time of early salvage radiotherapy treatment. The dose recommended is anywhere from 64.8 gray to 70.2. So 64 or 66, which we mentioned about in the cases, are very, very appropriate doses which should be considered. So I would say for the high and very high risk, where the the risk is high, there is a trial, the SPORT trial, which is a positive trial. The interim analysis have been published last year. And it shows that again, the soft point, the biochemical free survival is significantly better. It's a 6% difference with a hazard ratio of 0.71. But it comes at an acute, a cost of increased GI and geotoxicity, as well as bone marrow toxicity, which was seen in this particular trial. So again, coming to these early salvage radiotherapy, when we are considering early salvage, also it's routine common practice that we should add ADT for 4 to 6 months at least, which is supported by the SPOT trial. And Vivek Venkat, very beautifully, went through this, Get to AFU 16 trial as well, where you give this gosuralenine single shot at the time when you start, on day 1, when you start the radiotherapy treatment, 10.8 milligrams subcutaneous, and then repeat it 3 months later. So that will cover you roughly for around 6 months or so. So there are no trials to say that 2 years or longer have got any major impact. But yes, the thing is, for very, very high risk, some patients may be considered, but the standard would be at least 4 to 6 months. Then we talk about the role of ADT. I'll just very simply summarize this. Kaustubh has presented in various factors. I would just make it very simple. When you look at the NCCN guidelines, there are various risk factors. So for the very low risk, and favorable intermediate risk, there is no benefit of hormone therapy, of adding ADT. So this group, you may consider omitting the ADT. For the unfavorable intermediate risk group, 4 to 6 month ADT is what is routinely recommended. So you could consider 2 months neoadjuvant, added concurrent, and maybe continue for a maximum of up to 6 months or so. Coming to the high risk and the very high risk, we initially, 2 decades back, Bola et al., 3 years was the standard of care. But with modern trials, we have de-escalated, and it's routine practice now to not consider it beyond 2 years. So the neoadjuvant hormone therapy treatment is recommended in these patients. And the reason we use this is there is a considerable reduction in the size of the prostate. So approximately there are 2 very large publications involving more than 1,000 patients, which have seen that you can have a 35% reduction in the prostate for large volume prostates. So whenever you've got a large volume prostate defined as more than 70 cc, 100, 110, 120 cc, you use neoadjuvant hormone therapy treatment to to reduce the size. And this has a statistical significant reduction in your dose volume histograms on your DVH analysis when you consider these patients, when you do your radiotherapy and get your rectal doses. So certainly it has a huge impact on the late GI toxicity, the rectal toxicity, when you use neoadjuvant hormone therapy treatment. The duration is roughly between 2 to 8 months. For someone with very, very large prostate, we have used it for 6 months, 8 months, get a significant reduction in the size of prostate, and then go for radiotherapy treatment, which is very safe. Adjuvant, just to summarize, 18 to 24 months is the current standard of care. Beyond 2 years or 3 years has shown to have is no superior compared to using it for 2 years. So that's it, really, folks. Thank you.
Thank you so much, Rohit sir. Sir, Kaustubh sir, anything that you would like to?
Yeah, I thank all the faculty, all the panelists, all the speakers. It has been a great academic extravaganza. I think we have covered quite a few pertinent issues in prostate cancer and prostate cancer radiation therapy. I must also thank the uro-oncologists and the medical oncologists to participate. It was not an easy task for them because it was a group of radiation oncology and most of the topics were radiation related. And we have a particular pattern which we have been learning over the last few years. But I think Dr. Santosh and Dr. Shivam, they did very well amidst a radiation oncology, a group of radiation oncologists. I think it has been a wonderful multidisciplinary scientific program. And I thank AstraZeneca for hosting us. I thank the Horizon and Cancer Research and Statistics Foundation. Mitali has worked very hard. Astra has worked very hard. I thank all the organizers, all the participants. Thank you.
Thank you so much, Kaustubh sir. And with your permission, we can conclude the meeting, sir.
Yeah, we conclude. Thank you. Thanks.
Thank you so much. Have a great evening, everyone. Thank you.
Hello.